Okay, so in this video and the next couple of videos I'm going to post, it's going to be about the descending tracts. What's the difference between the ascending and the descending tracts? Real quick, before we continue on the video, let's remember we have our, what is this guy? This is our cross-sectional view of the spinal column, right? Looking down into it. Remember we talked about the cranial, like the skull, and we talked about the foramen magnum. And what ran through the foramen magnum was the spinal cord. So now if we take that spinal cord, cut it in half, we're back to our main structure. Or the structure we've been talking about in the past videos. So here we go. We're going to draw them real quick. We're going to do that, we're going to do this. Okay, and if you guys recall, up here we have the posterior, and down here we have the anterior, right? Another word for posterior, dorsal. Another word for anterior, ventral. And what are these two regions? They're the posterior great horn, and the anterior great horn. The posterior great horn did what? It received information, and it did what with this information? Okay, so in the previous three videos, we talked about the ventral white column. We mainly focused on the dorsal white column and the lateral white column, but we talked about three different tracts. What tracts did we speak about? We spoke about the anterolateral system, we talked about the spinothalamic tract, and we also spoke about the spinocerebellar tract. Okay, the first tract we also spoke about was the medial Laminisci pathway, right? That medial Laminisci tract. He was up here in the dorsal white column. And then we mentioned the spinocerebellar and the spinocerebellar and spinothalamic. These two tracts, right? They were in the lateral white meniscus region, the lateral white column. Okay, so what do these three tracts do? If we remember what these three tracts were, they were in the white matter and they were all ascending, right? They all ascended. What does it mean to ascend? It means to go to the brain. And when it goes to the brain, what is it used for? Only sensory information. No motor information, sensory information. Okay. The next videos, we're going to talk about descending fibers, like I just said. Okay, so descending fibers, where are they going to take place? The descending fibers are going to be in the lateral white column, and they're going to be in the ventral white column, and they're going to go down. Why aren't they going to be in the dorsal white column? Well, in the dorsal white column, we do not have any descending tracts. We only have ascending tracts. Okay, whatever. So the descending tracts are going to be in both the lateral and the anterior or ventral columns. Now, why did I go on this down that little rabbit hole? Well, because descending tracts, not all of them are going to proceed down to our toes or down to our ankles. Some of these tracts are going to stay where? From our head down to like our eyes and to our chin. Some of them are going to go all the way down our back to our arms, down to our legs, etc. So I'm going to take it from the top, and the first tract we're going to talk about is the Corticobulbar Tract. What does the Corticobulbar Tract mean? Okay, so it's the root word, or the Latin word, means the Cerebral Cortex and the Medulla Oblongata. Okay, what we're primarily focusing on is the Cerebral Cortex. Why? Well, this is where this tract is going to run from. He's going to start off at the cerebral cortex, and he's going to proceed down the body, and he's going to differentiate or innervate different structures. What are these structures? Here we go. Okay, so another word for cerebral cortex is what? The motor cortex. That makes sense. If this cerebral cortex is sending descending fibers, and we know that's motor control, it would make sense that this cortex is known as the motor cortex. It is sending motor information. Good. Now for this Corticobulbar Tract, where are we going? So we're going to start off up here. I just have like little bulbs, right, at the cerebral cortex. This is really a sagittal view, like you're seeing it from the side. You're not seeing it dead on. You know all my pictures I draw dead on? Well, on this picture, I'm drawing it from the side. Why? Well, our body, we said, is symmetrical. We have left and right. However, these nerves kind of run down to the right side of the face, and it's much easier to explain it if I'm only talking about one side. If I'm talking about both sides at the same time, things are going to get like all jumbled up. So I'm just going to talk about the right side. But remember, whatever happens on this right side is going to happen exactly on the left side. So if I'm talking right here, remember, the same exact thing is going to be mirrored on this, down this way. Okay, so we start off at the cerebral cortex. Boom. All of these things, they can converge, come together, and they pass through the corona radiata. Okay, it's just a structure in the brain. This corona radiata, right, the fibers continue down, and they pass through the internal capsule. Fine. After it passes through the internal capsule, it's going to pass through the midbrain. Okay, what's at the midbrain? The crus cerebri. The crus cerebri is in the midbrain. Fine. As it passes through, it's going to pass into the pons. We talked about him. We're going to go further into detail into the pons in a little bit. But let's just talk about the tract first. It's going to pass through the pons, and it's going to pass through the medulla. Whoa, what was the medulla? Well, we just said this corticospinal tract was the cerebral cortex and the medulla oblongata. So it's going to start here, and it's going to continue passing through, ending around at the medulla. But that's not too important right now. What is important about those fibers? What is the most important thing about these? Well, from the cerebral cortex, or the cerebral cortex, right, all the way down towards the medulla, this is known as an upper motor neuron. Okay, so we have upper motor neurons, and what are upper motor neurons doing? Well, upper motor neurons come directly from the brain through the spinal cord, and what do they target? Well, they target different regions of the body, and when they target a different region of the body, these regions are then going to branch out or shoot out to other things. What are these other things? Well, the other things that they shoot out to are going to be the muscles that perform the action. So the lower motor neuron is going to target the action, and the upper motor neuron is the one stimulating it. Not too bad. This pathway is really not as complicated as the last one. So, it does get a little confusing, so that's why if you notice this board, I didn't draw as much as I usually draw. I'm going to draw it in as we go on, because it would have been too mixed up. So first, upper motor neurons, right, coming from the cerebral cortex, come all the way down. But as they come down, what do? Well, they branch. Unfortunately, everything we talk about here on out is probably going to branch. Okay, so the first branch, I'm just saying it's the first branch because it's the most superior when we're talking about the nerves. So the first branch is going to be the cranial nerve. Cranial nerve 5. Okay, what was cranial nerve 5? We've talked about him a lot in our past lectures. This is the trigeminal nerve. What was the trigeminal nerve? Okay, cranial nerve 5, trigeminal nerve, tri for 3, meaning it has 3 different branches. Okay, if you remember, well, let me show you this right here. This is the lower motor neuron. That's representing the different innervations and ways that things are going. That's why I drew that right there. I'm going to erase them for now. And we're just going to talk about cranial nerve 5. So CN5 branches out into 3 different regions, V1, V2, and V3. Okay. Now, if you guys remember, V1 was what? Oculomotor. What was V2? Maxillary. And what was V3? Well, V3 was mandibular. Now, what is important to talk about this trigeminal nerve? V1 and V2 were mainly sensory. Okay. So if they're sensory, right? And you're thinking, okay, Joe, you just said this is all motor. Exactly. So we're not worried about the V1 and V2 branches. We're only worried about this V3 branch. Decent. This V3 branch is the mandibular, and he is motor. Okay, if he's the mandibular, what does mandibular mean? Mandible, right? Or mandible. What is the mandible used for? Well, the mandible is used for chewing. So what muscles are going to be innervated by this V3 region of the mandible? Are chewing muscles, muscles of mastication. So boom. The first thing we have is cranial nerve 5. We have to remember V for 5 in Roman numerals. And we're going to branch 3, so V3, muscles of mastication. Good. Now, I know this is weird, but you see I have these little ipsi to upper, ipsi to lower. I'm going to talk about that after. I just want to talk about the base first. I want to build a good foundation, and then we're going to talk about the other add-ons, right? The most important thing is knowing where things go. So now, we did 1. The second one is called cranial nerve 7. It makes sense. You went from 5 down to 7. We skipped 6, but why? Okay, you know what? Let me say that. Why did we skip 6? So, if you see over here, right, the cerebral cortex, or the bulbar tract really stimulates or innervates four things. Cranial nerve 5, cranial nerve 7, the nucleus ambiguus, which composed of 3 cranial nerves, which I'm going to get to, don't worry, and then the hypoglossal nerve, cranial nerve 12. So you have 5, 7, 9, 10, 11, and 12. There's a lot that are missing. Well, the 3 main ones that are missing that are not directly stimulated by the corticobulbar tract, but are like secondarily stimulated are 3, 4, and 6. So cranial nerves 3, 4, and 6 have not direct innervation, but secondary innervation. And what are 3, 4, and 6? Remember what these cranial nerves are? If you don't, it's fine. The best way I remember it is 3, 4, and 6 makes your eyes do tricks. Okay, so these cranial nerves do some things with your eyes. But we're not going to go into detail with them because they're not directly innervated by the corticobulbar tract. Now, where were we? Cranial nerve 7, facial nerve. We went from 5 to 7, skip 6. Okay, the craniofacial nerve, unfortunately, branches, because we said most of these things are going to branch, into 2 different regions. It branches into an upper region and a lower region. Okay, and what are these upper and lower regions? This is going to be the regions of the face, because it's the facial nerve. Okay, so the upper region is going to be the upper part of the face, and the lower region is going to be the lower part of the face. Makes sense. And if it's a facial nerve, what are the muscles going to be used for? Are they going to be used for chewing or mastication? No, that was trigeminal nerve, V3. They're going to be used for muscles of facial expression. What are these? Frowning, like frowning my face, smiling, going like wrinkling my forehead, I mean, like that. Frowning my face would be like this. I don't know, I'm all wired up right now. So just like cheeks, like all this different stuff is your muscles of facial expression. Know that. I'm going to talk about the 2 different divisions and why there's 2 different divisions in a moment. Just let's keep going through this. Now, the nucleus ambiguus. Okay, why the hell do we have that? Well, instead of saying we're going to cranial nerve 9, or we're going to cranial nerve 10, or cranial nerve 11, we're just going to say we're going to this nucleus ambiguus, which is 3 cranial nerves joined together. Let's follow him down. We follow him. And he branches, like we said. Why? All these things are branches. And the nucleus ambiguus contains 3 cranial nerves. 9, 10, and 11. Do we remember what these nerves were? If not, it's fine. 9 is glossopharyngeal. And what was the glossopharyngeal nerve used for? Well, it was used for the pharynx, the larynx, the soft palate, and the uvula. Okay, I'm going to edit that out. Okay, so now, as we said, we continue down the nucleus ambiguus. We have cranial nerve 9, 10, and 11. Fine. Now what? So cranial nerve 9 is going to be the glossopharyngeal. Cranial nerve 10 is going to be the vagus. And cranial nerve 11 is going to be the accessory. Chilling. What do these 3 nerves do? Well, these 3 nerves innervate a couple structures. They work together though. So parts of 9 help stimulate parts of 10, which help stimulate parts of 11. The pharynx, the larynx, the soft palate, and the uvula. You know, a little punching bag in the back of your throat. Okay, where are these things? Well, the pharynx and the larynx kind of line up right next to each other. So does the soft palate and the uvula. These muscles help with what? These are the muscles that help you swallow. They help you breathe. Okay? Good. Now, one more I want to talk about before I get into the whole chunk of everything. The hypoglossal nerve, cranial nerve 12, is the last nerve or the last thing that's getting stimulated by this upper motor neuron coming from where? The cerebral cortex. Good. Cranial nerve 12, unfortunately as it is, deviates again into the upper and lower regions. Okay, but you think it's the upper and lower regions of the face? No. What was the hypoglossal nerve known for? Well, it was known for the tongue, right? The tongue muscles. Now, the upper region is going to be for all the tongue muscles except one of them. The only one that it's not going to be used for is for the one that's contributed by the lower, and that's going to be the genioglossus muscle. So the genioglossus muscle is the only one that's not being targeted from the upper region. It's being targeted from the lower region instead. Good. Now, before I get into more and more of this detail, I just want you guys to get a quick run through of this one more time. Cerebral cortex goes through the corona radiata, through the internal capsule, through the crus cerebri, through the pons, through the medulla, as the upper motor neuron. From the midbrain down through the pons, it kind of like branches out. Branches into the cranial nerve 5, which is trigeminal nerve, cranial nerve 7, which is the facial nerve, nucleus ambiguus, which is the cranial nerve 9, 10, and 11, glossopharyngeal, vagus, and accessory, and finally into the hypoglossal nerve, cranial nerve 12. Now, I'm going to continue and I'm going to talk about the different ways that, in particularly, cranial nerve 7 and cranial nerve 12 are innervated on either side of the body. Okay, so now we talked about the 4 different regions, cranial nerve 5, facial nerve, nucleus ambiguus, and hypoglossal. Now, unfortunately, for the way we have to study, they don't directly stimulate the left and the right sides of the body. Because remember, we're going to have 2 of these, 2 of these, 2 of these, and 2 of these. Body symmetrical. You would think the right side stimulates the right side of the body, and the left side is going to stimulate the left side of the body. Well, this is fortunate for our body, because if one side of our body gets damaged, we're going to have a little like collateral help from the other side. You know, they're going to help each other out. What does this mean? Well, they compensate. We're going to talk about it. We're going to start off with cranial nerve 5. Cranial nerve 5. So I'm going to redraw all of them, not detailed, just very small, briefly. I kind of have it written down there, but don't pay attention to it. It's not the best. So I have the cortex, right? What is this cortex? Well, it's the cerebral cortex. And we're going to have a right side, and we're going to have a left side. Obviously, right side and left side. Now, remember this was a sagittal view from this way. When I draw this one, I'm going to draw it head on, right down Broadway. That's how I'm drawing it. So now, the right side is going to come down. The left side is going to come down, just like that, just like this picture. This is the right one, right? We said this is the right side. The right side came right down. Pass through the corona radiata, internal capsule, through the midbrain. Same thing. We're going to pass through what? The corona radiata. What else? The internal capsule, and then the midbrain, known as the crus cerebri. Good. Same thing on the right side. Boom, boom, boom. Now, if we continue proceeding down, we're going to have to stimulate what? We're going to stimulate cranial nerve 5. Okay. I'm just going to write cranial nerve 5 as C and V. C and cranial nerve V for 5. Okay, so C and V. Now, fortunate enough for cranial nerve 5, he's not too complicated. What do I mean by that? Okay, so he's getting stimulation ipsilaterally. What does ipsilateral mean? Same side. Okay, so he's going to have ipsilateral stimulation from the right and ipsilateral stimulation from the left. Why is this important? Okay, so if we were to get a lesion on the right side, right? Our right mandible is not going to be able to chew. It's not that good. So how do you make up for that? Fortunate enough, in our body, for cranial nerve 5, we have ipsilateral stimulation or innervation, and we're also going to have contralateral stimulation. So boom, this is the left side. He's going to also target the right cranial nerve 5. The right one, boom, same thing, contralateral. He's going to target the left cranial nerve. So, okay, if we have a lesion up here, what does that mean? What's a lesion? Like something wrong, damage, etc. If we have a lesion on the left side of the cortex where cranial nerve 5 is going to target, so we have a block, right? An inhibitory thing. Are we going to be able to chew? Yes. Why? Because the cortex on the right side of the cranial nerve is going to compensate and still give innervation and supply to cranial nerve 5. So it has both ipsilateral and contralateral innervation. Not too bad. Who else is like him? The nucleus ambiguus is the same exact thing. So I'm just going to erase this right here real quick. And I'm going to write nucleus ambiguus. And on this side, I'm just going to abbreviate it as NA. And what cranial nerves are these? 9, 10, and 11. Remember, glossopharyngeal, cranial nerve 9, 10, vagus, and 11 was what? Accessory. So boom, 9, 10, and 11. Why is this important? Okay, we're going to get through it right now. So if we have 9, 10, and 11, let me box them in, with contralateral and ipsilateral stimulation, if this lesion happens on the left side of our cortex, are we going to be able to breathe and swallow? Yes. Why? Because our right side is going to compensate for it. Very, very important. Just think, these are very crucial structures to our survival. If they're so crucial to our survival, we're going to need them. If one's damaged, we need to help the other one out. Now, crazy, I don't know why, but the body, maybe it's the safe space. Let's think of it that way. The body is going to try to do different things with the facial nerve and the hypoglossal nerve. We're going to talk about it right now. It doesn't do ipsi and contralateral innervation like which two things? Like the cranial nerve 5, trigeminal, and then nucleus ambiguous, cranial nerves 9, 10, and 11. How are these going to work? Okay, so now I know this is going to get very detailed, but it's okay. We're going to talk about cranial nerve 7 and the cranial nerve 12, facial and hypoglossal. Are they important to our body? Yes. Are they as important and as crucial to cranial nerve 5 or nucleus ambiguous? Not really. I mean, cranial nerve 5 is for chewing, which is important, but the nucleus ambiguous was for what? Breathing and swallowing. It's pretty important. So you would need contralateral and ipsilateral supply on both regions. I'm not saying that cranial nerve 7 and cranial nerve 12 are least important and we're not getting both supplies. I'm just saying it's different. What do I mean? Here we go. So the cortex, right? We have the cerebral cortex. We already said what it does. And we're going to have a right and a left one. Body symmetrical, left side, right side. Okay. Now, remember over here, I wrote we have an upper region and a lower region. What's the difference between the upper and the lower region? We're going to talk about it right now. We're going to write right over here. We're going to have upper region of the face. Remember, this is cranial nerve 7 we're doing, so I'm going to write CN7. And then we're going to have on the right side, upper region of the face, 5. Now, what are we going to have on the bottom? We're going to have the lower region of the face, and then we're also going to have the lower region of the face on the right side. Not bad. So, how are these different regions stimulated? And what are these regions? So the upper region is not exact, but mainly from the zygomatic bone of our cheek and above. And the lower region is going to be from that zygomatic bone and below. Give or take a little bit, but that's how I'm going to remember it, so I process it. I'm thinking zygomatic bone, like the halfway point. Above is going to be like my eyes, my forehead. Below is going to be what? My mouth, my lips, etc. Not bad. So, yes, we're going to have ipsilateral supply, obviously. Where's this ipsilateral supply going to be? Unfortunately, the left one is only going to target the upper region of the left facial zone. The right side is only going to target the upper region of the right facial zone. This is our ipsilateral supply. Okay. Now, what is not going to be ipsilateral? What's going to be contralateral? Two different things. What are they? I'm going to draw them in a different color. I'm going to draw them in purple for contralateral. So the left region, yes, he is going to help innervate the upper region of the right side. Why? You know, they try to help each other out, collateral support, they compensate if something goes wrong, which obviously something always goes wrong. And then the right side, right upper side, is going to then target the upper region of where? The left facial side. In case we have a lesion up here, the upper side and the left side will be okay. Now, you're like, Joe, buddy, you're missing two. Yeah, I know. The lower region. How are they getting supplied? Okay. These lines are getting crazy, so I'm going to draw them in blue just to match, right? The lower facial region, so from the zygomatic bone about and below, from my right side of my face, he's coming from where? He, unfortunately, is going to come from the left side. Of course. So if he comes from the left side, he targets here. This is called contralateral. We know that. What does contralateral mean? Opposite. I didn't spell that right, but it's fine. Now, the right side, where is he going to target? Obviously, the left side, because our body's mirrored. So we're going to target the left side. Now, it's crazy, right? Let's do a quick example. What's the example we're gonna do? I'm gonna draw a little face, and I'm gonna make him smiley, even though the condition he has right now, he's probably not smiling. What's this condition? Okay. If you have a patient, right, and they come in with you and they have a lesion, right, and you notice that, or you figure out the lesion is in the corticobulbar tract, and they come in with either, it appears to be a stroke. How are you going to differentiate between a stroke and from Bell's palsy? What was Bell's palsy? The paralysis of the face. And how do we have paralysis of the face? Remember, we said we walked into a cold area, instant shock to our face. That instant shock did what? Damaged our 7th cranial nerve. Okay, so if he damaged the 7th cranial nerve, what did he really damage? Well, he damaged both the upper and the lower regions. That's what Bell's palsy was. It comes from an instant shock, trauma, different types of drugs, etc. It's damaging this cranial nerve. Now, if we're talking about a stroke, is it damaging the cranial nerve? Maybe, but what we're going to focus on, the usual, like the normal, so I can never say anything is definite, either the upper, it's going to damage the upper region. Okay, well, so like how can you distinguish that Bell's palsy and a stroke? Don't worry, don't worry. Here we go. So now, I'm going to say from the left side of my face, right? We have the left right there, and we're just going to say the right there. And what am I talking about? The cortexes, right? It's coming from the cerebral cortex down. Okay, so the left side, right? We went down ipsilaterally, and what did we hit? The upper region of where? The left side of our face. So I'm going to draw the upper region in purple, and it's going to be this region right here, from there to about up there, maybe a little lower, give or take. Okay, and then what else did we say? Where did the left side of my face get innervated from? Did it come from the left region? No. Where did he come from? He came from the right side. How? So we have this coming down, right? Comes down, he targets the upper region, ipsilaterally. And then where's the contralateral side come? I'm going to draw it in a dot. I'm just going to dot it, right? He comes across the right side, and he is going to innervate this part of my face, the lower region of the left side of my face. Okay. Now, patient comes in, right? Their mouth, we're going to draw it a little droopy. I'm going to try. All right, it's a little droopy. Their eyes, maybe something's wrong with them. Okay, how can we determine where the lesion was? Well, if we see that the mouth is droopy on the left side, right? Are we going to say, okay, well, if the mouth's droopy on the left side and something might be wrong with the right eye, if something's wrong with the right eye region, right? Like maybe it's squinty or droopy, are we going to think it's a stroke? No, we're going to think it's Bell's palsy. How are we going to determine it's a stroke? We're going to say, hey, I know you're suffering right now, like it's hard, but can you wrinkle your forehead? Can you make it like squint? Maybe squint your eyes. If they could do that, if they can move their eyes or get little wrinkles on their forehead, right? That means they suffer from a stroke. Why? Because yes, the right side, we said the right side is damaged. Okay, if the right side is damaged, is this upper region completely turned off? No. Why was he not completely turned off? Well, we said as long as we have ipsilateral side to the upper region, we also have contralateral supply from where? The left side. The left side also targets the right upper region. The left side also targets what? The left lower region. Okay, so now the right side is ipsilateral and it's targeting the upper face. However, our lesion, right? Say our lesion occurred on the right side up here. That means this whole side, like the left upper face and the right lower face, or if we're looking this way, I'm sorry. If the right upper face is affected, and then the left lower face should be affected. However, we got some backup. Remember, the backup comes from where? The left side. The left upper region helps this side to be good. He compensates it. So now, that's how you can distinguish between Bell's palsy and a stroke. I know it's a lot of crazy mismatch, and we're going to do it one more time for the hypoglossal nerve. Okay, so now, last one, thankfully, right? We're going to talk about the hypoglossal, the cranial nerve 12. So we're going to write CN, what is it? XII, I believe. Not good with my Roman numerals. XII. Good. So now, what do we have? A left side and a right side. We talked about that. Left and right. Okay. Fortunately for us, the tongue is just like the facial nerve. However, it's for the tongue, not the face. Okay. Not bad. The left side and the right side are both going to come down ipsilaterally. What are we going to target here? Let me keep the colors consistent, right? We're going to target the upper, and we're also going to target the upper on this side. Okay, so you have an upper tongue and you have a lower tongue. Now, what about the lower tongue? What are those going to be? Well, we're going to have lower, and we're going to have lower. How are these guys supplied? Okay, well, let's talk about it real quick. We know the right side of the upper region of the tongue is going to target both the right side, and he's going to help compensate the left side. Same with the left side. The left side is going to ipsilaterally target the left side, but he's going to help compensate the right side. Not bad. Now, the lower regions, how are they supplied? Unfortunately, the right side is supplied by the left side is supplied by the right region, and the left side of the tongue, right? He's supplied by the right region. The right side of the tongue, he's supplied by where? The left region. Okay, so it's that contralateral crisscross. We know that, we spoke about it, but let's do the example that, I don't know, I've seen a lot of practice questions on this example. Let's just go through it. Okay, so I'm going to draw a tongue. Okay, that's our tongue, right? Now, if we have a lesion, where? If we have the lesion on the left side, right? Actually, I'm going to draw the tongue directly underneath, just so I could draw it a little bit better. I'm going to draw the tongue just like that, right? That's our tongue. Now, what could occur? So, if we have a lesion on the left side, what is getting stimulated? Okay, we follow the left side down, right? Here's the lesion. Well, are we going to have function over here? I'm going to write in green a plus sign, meaning yes, you have function. So, over here, we're going to have function on the upper region of the left side of the tongue, even though we have the lesion's going to be in red. Why do we have function on the upper side? We spoke about this. The contralateral help from where? The right side. Okay, if the lesion's on the left side, let's talk about the right side real quick. Or we'll continue down. Are we going to have function on the left side of the lower part of the tongue? Yeah. Why? Is this lesion targeting the left side of the lower? No. No, it's not. We'll get there. So we're green, we're good. This whole left side of my tongue is good. Now, right side. Is the right upper side intact? Yeah. Even though the contralateral help is not there, we still have our ipsilateral supply. So the right upper part is fine. So we're going to write pluses, right? Now, as you guys could assume, where are we going to have our damage? So if the left lesion is here, the blue line goes to the right side of the lower tongue. We're going to have damage here. Okay. Now, what does the lower part do? What does the lower part of the tongue do? Well, it protrudes the tongue. What does that mean? It makes it stick out. Sticks your tongue out. Okay. Now, when it sticks your tongue out, it also helps move it to the left or moves it right. Which side does what? Okay, so if your tongue sticks out, right, on the left side, or if this region, right, is helping sticking your tongue out, it's really pushing it to the right. Okay, why? We'll go over it. So this side, this would be the left region, is going to protrude your tongue out and to the left. This region, in red, when it sticks your tongue out, or the right side of your tongue, is going to protrude it out and push it to the right. Now, if I split my tongue down Broadway, right down the middle, I'm going to have the left side and the right side, like we said before, left and right. Okay, the lesion's here. Someone has a lesion in this tract in the cranial nerve 12, right? The right and lower cortex. If they stick their tongue out and it is protruding out and it's hanging to the right side of their face, where do we think this lesion is going to be? Well, this lesion is going to be on the left side. Why? Because the left side, right, pushes the tongue which way? The left side pushes the tongue to the left. However, if they have the lesion on the left side, you can't push it to the left. If you can't push the tongue to the left, the right side of the tongue is going to overcompensate. He's going to push it so far to the right. If he's pushing it so far to the right, your tongue's going to be leaning to the right. It can't even go to the middle. It's going to be really sticking to the right side of the face. So, one more time, real quick. We have this is how I kind of remember it. If you're sticking out your tongue, right, and the left side is damaged, the tongue cannot go left. If you stick out your tongue and the right side is damaged, the tongue can't go where? Tongue can't go right. Because what? These two lesions push each other in opposite directions. So the left side, right here, is stimulated by the right region. This side here, the right side, is stimulated by what? The left region. Now, protrude the tongue tongue protrudes to the right side of the face. Where is this lesion? Like we said, it's going to be left side. If you stick the tongue out and it protrudes to the left side of the face, where is this lesion going to be? Right side. Okay. I know this is a lot, and I'll do a practice question or two, but I hope this video really helped, guys. Okay, so we're going to do a couple questions. Quick disclaimer, I took these questions from ninjanerd.com. He really helps me learn all this material, and his questions are really great under the notes that he gives us. You just have to, I think it's a little subscription, like you could do like a half a year or something like that, a year or 2 year subscription. And he adds his notes with like 5 or 6 practice questions from each chapter. But here we go. So we're going to say the corticobulbar tract has several destinations. Which of the following is not one? We should know this one. Where does it start from? The corticobulbar tract? Well, it starts from the cerebral cortex, right? Cerebral cortex. And where does it travel through? It travels down. It passes through what? The first region is known as, we said it, the corona radiata. Then it passes through the second region known as internal capsule. Okay, you want me to expand it a little bit? Corona radiata. Then it keeps passing through what? Passes through another region known as the midbrain. We said this. Keeps proceeding down, proceeds down into the pons, and then where? The medulla. Sorry. Okay, then to the medulla. Now, between the midbrain and the pons, it kind of branches, right? 4 different ways. Do we remember what they were? Well, that's the only way to answer this question. Unfortunately, we can't get ourselves out of this one. It's cranial nerve 5. It's cranial nerve 7. Which was cranial nerve 5? Trigeminal. What was cranial nerve 7? Facial. Should do V. Should do VII. We got nucleus ambiguous. And now, if the question, I don't know if it did, I forgot, but if the question doesn't give us nucleus ambiguous as an answer choice, and it gives us CNIX for 9, or it gives us X for 10, or it gives us XI for 11, we should know any of these 3 are part of the nucleus ambiguous. Okay, and then the last one it gave us, or the last one we know, is cranial nerve 12. Or I should write XII, and this was the hypoglossal. Fine. So now, knowing these structures, we should get the answer. The corticobulbar tract has several destinations. Which of the following is not one? Is hypoglossal nucleus one? Yes, it is. What was this? Cranial nerve 12. Is nucleus ambiguous one? Well, yeah, it was. What was this? We just said cranial nerve 9, 10, and 11. Okay, was red nucleus one? I don't remember seeing that. What about trigeminal nucleus? Good. What was this? Cranial nerve 5. So yeah, I know I write it as the abbreviations, but guys, you have to remember what these nerves are. 5 is trigeminal. 7 is facial. 12 is hypoglossal. 9 is what? 9 is glossopharyngeal. What is 10? Vagus. I'm not even spelling right, I'm sorry. 10 is vagus. And what is 11? XI. Well, this is accessory. So I know, it's hard, but it's very important. Okay, so we know our answer right here is what? B. This is the only one not involved in the corticobulbar tract. Okay, continue down. Regarding the innervation of the lower portion of the left facial nucleus. Okay. What are they asking us? Regarding the innervation of the left portion of the left facial nucleus, it's supplied by both the left and the right corticobulbar tracts? Maybe. It's supplied by the left corticobulbar tract, or is it supplied by the right corticobulbar tract? Okay, so what was the facial nucleus? We said it was cranial nerve what? Cranial nerve 7, VII. And then we said from the cortex had a right side and it had a left side. And then what did we go to? We went to an upper regions on both sides. And then we had a lower region on both sides. Okay. And we said the upper regions were ipsilateral and then a little contralateral support. But the lower regions were what? The lower regions were only contralateral. Okay, so now it's supplied by both the left and right corticobulbar tracts. They're asking us for the lower portion of the left facial nucleus. So they're asking us for what portion? This portion right here. Is it supplied by both left and right? Absolutely not. Is it supplied by the left corticobulbar tract? No. Is it supplied by the right corticobulbar tract? Yes. Why? If we look right here, let me highlight it. This guy is coming from where? The right corticobulbar tract, and it's supplying the left lower portion of the left facial nucleus. Good, we know this. These questions should be a walk in the park for you guys. So now the left corticobulbar tract, so we're talking about the left side up here, does what? Does it supply the lower portions of both the right and left hypoglossal nuclei? Let me go back real quick. Let me erase some of this stuff that I drew. And I'm just going to, what am I going to do? I'm going to draw. I'm going to lasso it. And I'm just going to move it down. Just so we could see it again. Okay, so now we see it again. Now, what is it asking us for? The left corticobulbar tract. Which one was that? That was this right here. The left corticobulbar tract. Does it supply the lower portions of both the right and the left hypoglossal nuclei? Well, the lower portion, it supplies the right side. Does it support the left side? No, because it does not target this one. The right one does. So that's wrong. Does it supply the right trigeminal nucleus but not the left one? Well, I don't even know if this is talking about, it might. I mean, it supplies the right trigeminal nucleus but not the left one. Is that correct? What is this even asking? Think about it. Right trigeminal nucleus. What does this mean? That's cranial nerve what? Cranial nerve 5. So what is cranial nerve 5? Does it have right and left ipsilateral or contralateral supply? Yes. CN5 was different than this one up here. CN5 had both. So cranial nerve 5, yeah, it supplies the right trigeminal nucleus, but does it supply the left? Does it not supply the left? No, it supplies both of them, so that's wrong. Okay? Does it supply the upper portions of both the right and left facial nuclei? And the lower portion of the right facial nucleus? Oh, here we go. Does it supply the upper portions of both the right and left facial nuclei? So we're starting from over here, and we're going to, yes, the right side, and we're going to the left side. So the first part is good. Is it supplying the lower portion of the right facial nucleus? Yes, it is. Right side of the lower facial nucleus. So boom, this answer is correct. Just for the fun of it, let's do D. Does it supply the superior portion of the right hypoglossal nucleus? Okay, so we remember hypoglossal is similar to this structure. And it supports the superior portion of the right. Yeah, it does. It helps it. Does it support the lower portions of both the right and the left? No, it does not support both of them. It only supports this side. So the hypoglossal, this question is wrong as well. So C is the only answer. Number 5, in Bell's palsy, damage to the right corticobulbar tract will cause what? Oh, guys, we knocked this thing out of the ballpark. We should know this one. If you don't remember it, we'll do it real quick one more time. We'll do the cortex. We'll do right. We'll do left. Right? We stimulate down to the upper region over here, upper region over here. Have the lower region here, have the lower region here. Do we crisscross? Where? Well, yes, but where? Up here and up here. How do we stimulate the left one? Well, the right side goes to the left, and the left side goes to the right. Okay, and now let's draw our face. I'll draw our eyes, our little nose, our mouth. Okay, Bell's palsy causes damage to the right corticobulbar tract, so we're talking about this side. Okay, is there going to be drooping of the left lower quadrant of the face? Well, if it's the right side, are we going to droop here? Yeah, because we're going to have the lesion. This is going to be affected. So already off the bat, we know our answer. But let's keep going. Are we going to have an inability to wrinkle the forehead? No, we will be able to wrinkle the forehead. Why? Well, if the forehead is from the upper parts, right, and the right side is damaged, we're still getting supply from the left region. So the left region is still innervating the right upper face. So we'll be able to wrinkle the forehead. So that's right. So this is wrong. Now, we're going to be drooping of the right quadrant of the face. The lower quadrant of the face. No. Why? The lower right quadrant of the face gets innervated from where? The left region. The left region innervates this one. So the only answer we could have is A. Now, I'll draw it out real quick. Right and left, right? And then we could draw it again. Left stimulates right here. Right stimulates over here, this whole region. And then what else do they stimulate? Well, the right also helps this side. The left also helps this side. Now, the left side only does this area. The right side only does this area. We know that. So if the right side is damaged, this side of the face is damaged. Good. Okay, here we go. We want to do one more question. This is a long one. A 65-year-old man known hypertensive visits the clinic with complaints of difficulty speaking and weakness on the left side of his body. Okay. Physical examination reveals left-sided hypertonia, spastic weakness, so we're going to underline that, of his upper and lower extremities, okay? And left-sided loss of position, sense, vibratory sense, and discriminative touch of his upper extremities, trunk, and lower extremities. Holy crap. When asked to protrude his tongue, okay, so something we know, protrude his tongue, the tongue deviates to the right side. Okay, so we know that. And what is the question asking? Probably cut off some of it. It's saying, what is damaged? Okay, so what is damaged here? Well, we should know. I'll take it from the top again, I guess. Right, cortex, left, right, both of them. What is the right target? The upper region of the tongue, ipsilaterally. Left does the upper region of the tongue, ipsilaterally. Then they do their little crisscross, right? They help each other out. Now, the right side targets the lateral, the left lower region. The left side targets the right lower region. Fine. Now, when you're asked to protrude the tongue, we'll draw our little tongue structure, a little lower. We're asked to protrude the tongue right down Broadway, right? Just left and right. The tongue deviates to the right side, so he's deviating which way? That way. Okay? So, let me erase that. I'll just draw the arrow like this. It's deviating that way. So what is damaged? Well, if the tongue deviates much to the right side, right, what works? Well, if we're talking about tongue deviation, we know the upper regions are intact because tongue deviation comes from protrusion, right? Protrusion of the tongue. Okay, so now what is damaged? This side or this side? The right or the left side? Well, the left side does what? The left side is right over here, protrudes the tongue to the right. It pushes it away from it. The right side pushes the tongue to the left. Okay, so if you're pushing, right, you're pushing either way. Pushing this way and you're pushing this way. If one side is damaged, so say this side is damaged. If this side is damaged, the tongue's going to go that way. Makes sense? Now, if this side is damaged, the tongue's going to go this way. Makes sense because this is not able to block it off. Chilling. Now, we know that. So, if the tongue is protruding or deviating to the right side, that means it's going this way. Which one is damaged? let me draw it in red. This one is damaged. So that is bad. This guy is effective. Okay. We should know the answer. How does this guy get innervation? Where does he get his innervation from? Well, if we proceed down the left side of the lower region of the tongue, follow it up, follow it up, follow it up. Oh, he doesn't get it from the right side. He gets it from where? The left side. So the left region. That's what's going to happen if the tongue is protruding to the right. All right, guys, I know this is a really long and drawn-out video, but I hope it helped.